Thank you. Congratulations, Dr. Rubin, and thank you very much for your beautiful talk and your reflections on the good, the bad, and the ugly. As Mira said, I am a GI pathologist. My presentation will have nothing to do with GI pathology, which means that unlike the prior three speakers who knew a lot about what they were talking about and had a lot to say, I don't know a lot about what I'm going to talk about. I don't have a lot to say, and we might catch up. Well. This is our case history. This is a 68-year-old man. He was a prior smoker, and he now has a 3.3 centimeter mass in his adrenal gland. The mass, they knew he had a mass. It had been slowly growing over the past 2 years. He does not have any documented history of malignancy. So as you can tell from this history, we're probably not dealing with an aggressive malignancy, maybe with an indolent neoplasm. He did undergo resection of his adrenal gland at an outside hospital. The adrenal gland weighed 35 grams, and it did show a 3 centimeter lobulated white tan mass. Not to mislead you, this gross photograph is not from this specimen. It is from a related entity from the internet, your friend. But this is the slide that you received for your review. And it does show under very low power a very cellular neoplasm. It does have some necrosis and hemorrhage, and it does extend into the periadrenal fat, as you can see here. Under medium power here, it has a solid, vaguely nested architecture with thin fibrovascular cores. There was lymphovascular invasion, and as I already told you, it was extending in the periadrenal fat. Under high power, you see that there is some anisocytosis, some variation in the nuclear size. There are irregularities in the nuclear membranes. There are occasional nucleoli, clearing of the nucleolus, and there's abundant pale pink cytoplasm. There were some mitosis seen. There weren't too many, but they were there, approximately 5 in 10 high power fields. So what is our differential based on the H&E alone? Well, there is a lot of pale eosinophilic cytoplasm, so let's start with our classic pink cell neoplasm differential. And this very classic differential includes a well-differentiated neuroendocrine tumor, an adrenocortical neoplasm, a hepatocellular carcinoma, as well as a renal cell carcinoma. In this case, we might want to include a urothelial carcinoma, a squamous cell carcinoma, and of course, a basket, because any carcinoma can have abundant pale eosinophilic cytoplasm. This patient was a smoker. We don't have any reason to think that he has lung cancer, but lung cancers do like to metastasize into the adrenal. So let's turn to immunohistochemistry, which is what we turn to as a first step. So this tumor was negative for synaptophysin and for chromogranin. So that makes a neuroendocrine tumor not so likely. It was negative for arginase 1, a marker that we like for hepatocellular differentiation. So, it was negative for PAX8, so that makes a renal cortical carcinoma less likely. Arginase 1 negative, which I said makes hepatocellular carcinoma less likely. It was negative for P63, GATA3, CK20 negative, and so urothelial carcinoma and squamous cell carcinoma are also not very likely. Now, what about adrenocortical neoplasm? Well, it did have some focal positivity for inhibin, which would be good for adrenocortical neoplasm, though it wasn't entirely clear that it was a non-specific staining. It did have some positivity for pancytokeratin, and that is not so good for adrenocortical neoplasm because they usually are cytokeratin negative. It was also negative for melon A, for synaptophysin, and for steroidogenic factor 1, which is a good marker for adrenocortical neoplasms. However, we do have to keep adrenocortical neoplasm in the differential because this is the only site of disease. He doesn't have any disease elsewhere. And of course, we have to keep our basket in the differential. It could be something else. So this was the initial diagnosis. Epithelial neoplasm differential diagnosis includes a primary adrenocortical neoplasm versus a metastatic carcinoma. Not a very satisfying diagnosis. Now, when you're dealing with an adrenocortical neoplasm, you have to opine about whether it's an adenoma or a carcinoma. And for that, you turn to the Weiss criteria or to Dr. Satish Tiku, if he's available, or to both. This table shows the Weiss criteria, and I'm certainly not going to go through them because they were confusing to me when I was a resident, and they still are. But suffice it to say that in this particular case, because of the presence of mitoses, because of the presence of some necrosis, because of the lymphovascular invasion, because of the infiltration of the adrenal capsule, it was felt that if this was indeed an adrenocortical neoplasm, it would represent a carcinoma. So faced with this very unsatisfying diagnosis, the treating physician for the patient thought, well, are there any additional tests that I can do to help me out? And the answer, of course, is that in this day and age, where especially in the West, we have way too many tests, yes, there's always an additional test you can perform. In this particular case, he turned to a molecular test for tumor classification. And this will take us to a little detour. The detour is going to be about molecular testing, some of their capabilities, and some of their limitations. It will be a brief detour, do not worry. So the test that he turned to was the cancer ID test for tumor classification. Now, this is a commercial test. And as a side note, I do not have any stake in the company. I do not endorse or unendorse, to use some of the language of our times, this particular test. I'm just talking about it because this is what was chosen in this particular case. This is how this test is being performed, and this is from the company website. They, as with every molecular test, they try to enrich for the tumor. Then the tumor goes into a test tube, and RNA is extracted. Then they use a reverse transcriptase to make a complementary DNA, and then that goes into a PCR assay that checks for the level in 92 genes. It's a 92 gene assay. And so the results from this 92 gene assay are compared to gene expression profiles from certain known tumor types, and they have a reference database of over 2,000 samples. The database that they have includes 28 main tumor types and 50 tumor subtypes. And this is the type of report that you get. So in the top, you get your main cancer type, the one where you have the highest probability that your tumor matches to. Then here in the bottom, you have the cancer types that are ruled out with 95% confidence. And then if there's some ambiguity, if there's some tumor types that are not ruled out, but are not the ones with the highest probability, then they're listed here as cannot be excluded. Now, the company website lists an overall accuracy in that test of 87%, and this comes from this publication here. When they did this study, they looked to see if there was any variability in sensitivity and specificity among different specimens that they had. And overall, they found that that wasn't the case. They had similar sensitivity for metastatic versus primary, well-differentiated, poorly differentiated, biopsies versus excisions. There were some exceptions. For example, here in the ovary, the specificity was only 57, compared with other sites where it was much higher. In a subsequent study, and I should say that unfortunately, the studies that are out there in the literature, they use commercial assays, usually are from investigators that have a stake in the company, and then sometimes sheds a little bit of a doubt in the results, though some studies are definitely very good, and obviously they pass peer review because they're published in good journals. In any case, in this subsequent study, they did compare the assay to immunohistochemistry. And what they did find is that in cases where the surgical pathologist used a limited number of immunohistochemical stains to arrive at the diagnosis, 1 through 9 immunohistochemical stains, then the accuracy was similar between the molecular test and immunohistochemistry. But in cases where the surgical pathologist used a lot of stains to arrive at the diagnosis, shown here, then the molecular test seemed to perform a little better compared to the immunohistochemistry. Now, what about the cancer type ID test limitations? Of course, they're there. The number of 87% accuracy implies that there are some limitations. I am personally aware of at least one case that was clear-cut a carcinoma, had diffuse cytokeratin positivity, but the cancer type ID test came back as melanoma. And then the clinician wanted us to explain why it wasn't a melanoma. And of course, I don't need to tell you that in this day and age, people think that molecular is 100% accurate. So then you have to explain to them why the carcinoma is not melanoma. It's not pleasant. But anyway. But some limitations can actually be explained, but by what you have under the microscope. And I just want to share with you this case of a gastric hepatoid adenocarcinoma. Now, a very poorly differentiated carcinoma, as you see here, it's stained with glypican-3, SAL4. Now, this presented in the liver. Now, anyone who has ever had a case like this knows that to diagnose a hepatoid adenocarcinoma that does not arise in the liver and to distinguish it from a hepatocellular carcinoma can be a near impossibility. But the possibility was raised that this actually was a hepatoid adenocarcinoma in this case, and then they did an upper GI endoscopy, and they did find a tumor indeed in the stomach. Well, it shouldn't come as a surprise to you that the molecular test came back as hepatocellular carcinoma or germ cell tumor. A gastric tumor was excluded with certainty. So it was, of course, it was really an astute surgical pathologist who raised the possibility that in the differential was a hepatoid adenocarcinoma that led to the upper GI endoscopy and the identification of the gastric tumor. Now, I didn't just want to talk about a commercial test, and besides, we're kind of obligated to talk about MSK impact here at MSK. I'm actually surprised that they let Dr. Chen talk without having an MSK impact slide. But Dr. Dallaire did tell you the specifics of this assay, so I'm not going to belabor it, of course. But it does give you information about single base pair substitutions, small insertions, deletions, copy number alterations, and select rearrangements in now 468 genes. And so I don't have to tell you that the frequency of these gene alterations vary among tumor types. For example, EGFR mutations are here in green, are much more common in non-small cell lung cancer. You don't really see them in colon cancer. Conversely, APC mutations, very common in colon cancer, but you don't really see them in many lung cancers. So you can take this genetic data, and just like the test that I talked about before, which was based on gene expression, you can take this genetic data and you can harness it for tumor classification. And this is actually something that the bioinformatics people here are actively doing using MSK Impact. And this can provide very important information. It does, of course, also have limitations. Now, this is an example where it did provide very powerful information. This was a 66-year-old female with a history of breast cancer that presented with a liver mass. And this is a poorly differentiated adenocarcinoma. It could certainly be her breast primary. The immunohistochemistry was a bit nonspecific, CK7 positive. It was negative for ER, PR, and HER2/neu. Unfortunately, we did not have the breast tumor to compare it to. So it could be metastatic breast cancer or not. When it went for sequencing, it showed that it had an IDH1 mutation, a hotspot mutation, R132C, as well as a frame shift mutation in BAP1. Now, these mutations, IDH1 mutations and BAP1 mutations, are not really found in breast cancer. They both are found in biliary cancer. biliary cancer shown here for IDH1, here for BAP1. And in fact, the combination of the two of them, here internally using the MSK impact data, we've only seen it in intrahepatic cholangiocarcinomas. So certainly the molecular data would suggest that this is indeed an intrahepatic cholangiocarcinoma and not her metastatic breast tumor. Now, we did want to confirm this by more traditional surgical pathology methods. And so we did perform albumin in situ hybridization, which was positive. Here you see these red dots indicating positivity. I'm not going to go into albumin in situ hybridization, but basically it's positive both in hepatocellular carcinoma and in cholangiocarcinoma, so you can use it as evidence that something is a primary liver tumor. Oh, I guess I did have some GI pathology. Okay. But there are limitations, and here's one interesting case. It's a case of papillary thyroid carcinoma, but not your typical one. It had a very interesting architecture, some papillary areas, some cribriforming, and some morules. And so this is actually a papillary thyroid carcinoma cribriform morular variant. It is a very rare variant, and it is important to make the diagnosis. And if you want to know anything about this, please talk to Ronnie Gassain, who will talk to you about it with tremendous passion. And he will tell you that making the diagnosis is critical because it is associated with familial adenomatous polyposis. I, as a resident, saw Dr. Gassain diagnose it in a young girl. And then after the diagnosis, she had genetic testing. They diagnosed her with FAP, and he probably saved her life. So since they're associated with familial adenomatous polyposis, they show APC mutations. And this is the MSK impact data that we got from this tumor. So there were APC mutations along with a SMARCB1 mutation. But when it should not really be a surprise to you what the tumor classifier said this was. Now, it went into the tumor classifier as a papillary thyroid carcinoma. It came out of the tumor classifier as a colorectal cancer. But no surprise, right? It has APC mutations because it's a particular variant of papillary thyroid carcinoma. So no surprise there. All right, so to end our detour, molecular data should be used in the context of clinical and histopathologic data. Very profound. Now let's go back to our case. For those of you that were really hating every minute of this detour and were really dying to know what the tumor classifier showed. So what did the cancer type ID say for this adrenal tumor? Well, it said that it's a meningioma. Now at this point, we can say that's just an artifact of molecular limitation. Or we can reassess the case. And we can look at the histology and say, it kind of looks like a meningioma. And then we can do some more immunos, which was done. EMA was positive, as you would expect in a meningioma. Vimentin, diffusely positive, as you would expect in a meningioma. The progesterone receptor was negative, which you would expect it to be positive, but it can happen. The Ki67 was done. It was 11%, a little elevated for a conventional meningioma, but certainly within the range of an atypical meningioma. So this is the final diagnosis, epithelioid neoplasm most compatible with a meningioma. And to boost our confidence in our diagnosis, there is a prior case report. Now, I'm not going to say much about meningiomas, especially since Dr. Hamid is looking at her watch. But there are, the majority of them are, of course, grade 1. And there are some, though, that are atypical. They have elevated mitotic rate or some abnormal cytologic features. And very, very few are actually anaplastic. Now, interestingly, the meningiomas are not supposed to be cytokeratin positive. And ours actually did have some positivity. But as they become increasingly malignant, they get more cytokeratin positive, which of course is a problem if you're trying to distinguish them from a carcinoma. Vimentin might be able to help you a little bit there. And along the same vein, progesterone receptor, while the benign ones are all positive. However, as they become more anaplastic, they tend to lose progesterone receptor expression. What about meningiomas outside the central nervous system? Well, they do occur. Meningiomas can metastasize, and this is actually the largest study I found out there that is a PubMed review, and they summarized 164 distant metastases reported in the literature. The most common site was lung, but other sites were definitely involved. The adrenal gland was not a preferred site of metastases, only one case having gone to the adrenal gland. So if you do happen to have a meningioma outside the CNS, first you have to rule out an intracranial primary or an intraspinal primary. And then if you have ruled that out, then you're left with a primary extracranial meningioma. And this is the largest study I could find on that particular topic, where they had 146 cases. The overwhelming majority, the overwhelming number of them were in the head and neck area. Only 6 were outside the head and neck area. What is interesting is that among those 6 cases, 5 of them were either atypical or anaplastic. Of course, the numbers are too low, and we can't draw any conclusions based on that, but it was just an interesting observation. What about theories about their pathogenesis? Well, there are theories. There is no proof. I don't know how we can prove one thing or another, but the 2 dominant ones are either a displaced Pachonian body, which I guess is another word for arachnoid granulation, becomes detached during embryologic development in an extracranial location, and that's what gives rise to the meningioma, or a multipotential mesenchymal cell, such as a fibroblast or a Schwann cell, is what actually gives rise to an extracranial meningioma. If you want to know more about meningiomas, Dr. Mark Rosenblum promised to talk to you about it more over drinks at the reception. No, he didn't really. So in summary, anything can happen, and when it does happen, I'm sure you will handle it with the wisdom that you have acquired during your days at Memorial. Thank you.